So my name's Alice, and I'm a member of the support services team here at Overcome, alongside my colleagues Anna and Annie. You can reach us on the support phone line. You can drop us an email. We have an instant chat feature on our website. You can even send us text, or you can schedule a one-to-one Zoom meeting if you would like to kind of meet with us that way. But we are absolutely here for any questions that you might have, any information that we might be able to help you to find, even just for a general chat. You know, if there's anything at all about your experience of living with cancer that we can talk through with you, please do get in touch. And we're available from Monday to Friday from 10 a.m. to 5 p.m. So the way that the webinar will be structured today is shortly I'll be passing over to our speaker. And at the end of the session, we will allow time for a Q&A. So as we go, you know, if a question occurs to you, please do feel free to enter it either into the Q&A box or the chat box, both of which you can find next to each other at the bottom of your screen. We'll be saving all of the questions for the end of the session, just to allow for, you know, a bit of a flow to proceedings. And what will happen is that we'll kind of come to them at the end. They'll be read out anonymously, so you don't have to worry about your name being shared. I might group similar questions together if they're on a similar sort of theme. And just a reminder really that our speaker, Dr. McVeigh, is not here today to offer individual clinical opinions. So do bear that in mind that when you're asking a question, the ones that will be picked out will be sort of general questions that might apply to, you know, a number of people in the session today. We may not have time to come to all of the questions, but we'll see what we can do, you know, get through as many as we can. So on that note, I will pass over to our speaker today, Dr. Terri McVeigh, who is a consultant oncogeneticist at the Royal Marsden. She's also a member of our expert advisory panel here at Overcome, and we're really, really grateful for her continuing to offer her expertise to all of us in that way. Thank you very much. So Dr. McVeigh, I'll pass over to you.
Amazing. Perfect. Hopefully you can see me and hear me. That's great. So it's lovely to be with you again this week. And as Alice said, I'm not sure if some of you were here last week where we did kind of the more common types of ovarian cancer, but this week we're going to focus on the really unusual types. So I hope you find it helpful. And just to reiterate, I'm so impressed with all the work that Overcome does. It's such a phenomenal organization, and I'm always delighted to be able to speak on their behalf and with all of you. As Alice mentioned, I work in the Royal Marsden in London, but you can probably guess from my accent that I'm transplanted from Ireland. So that's where I trained originally. Just to give a brief overview of what we plan to cover today, I will recap the genetic basis of cancer generally, because I appreciate not all of you would have been here last week. For those of you that are, the slides will be vaguely familiar, but I think it's important that we just distinguish between hereditary causes of cancer and those genetic changes that happen by chance in the cancer cells, because people often worry when they hear the word genetic because they assume that that is something hereditary, but it's not always actually. And most genetic changes that happen in cancer are not hereditary, but obviously the terms can be very confusing. So we'll just explain the difference between those. We'll talk a little bit about how ovarian cancer is classified. I'll try not to bamboozle you completely with the kind of pathology features, because I'm not a pathologist myself, so I won't claim to be an expert on that. But we will talk just broadly about how they're classified into the different types, and then we will think about hereditary genetic risk factors for the rarer subtypes, and I'm sure many of you on the call are actually probably people that have had those rare subtypes, which may explain why you're interested in this topic. Cool. Okay, so when we think about hereditary risk factors for cancer, what we mean by that is that there's a genetic change in all of the cells of your body. It's something you were born with. You may well have inherited it from one of your parents, and if we take a blood sample from you, we will find that spelling mistake in your genome. And equally, if we test a sample from your tumor cell, we will find that spelling mistake as well. Okay. And that gets a little bit complicated because we're doing more and more of this tumor-based testing to try and identify the genetic kind of what we call drivers of cancer. So the aim of the game really is if we can identify the kind of genetic prompt that caused the cancer or that caused the normal cell to become cancerous, you know, that'll improve our diagnosis because it may mean that you can subtype a cancer more accurately. It may mean actually that you prescribe different drugs than you would have previously. So we're doing loads and loads of tumor-based testing. And for people where the cancers have acquired these random genetic blips over time, you'll find those genetic blips in their tumor, but it won't be present in their normal cells. So it won't be present in the blood sample. But it can be a bit confusing if you've started off by doing the tumor test because you're not always able to figure out if something is inherited or not just by looking at the tumor DNA. So we will often recommend that if somebody has had tumor-based testing and something weird is found in the genetic makeup of the tumor, we may recommend that they have blood-based testing then to figure out if it's inherited or not. But there's only certain genetic alterations that we would recommend that is done for, because only certain hereditary changes in genes are associated with cancer risk. There's some other genes that are implicated in cancer that will give you a completely different picture if you inherited it. So that's why I'm able to look at a genetic report from a tumor and say, no, that's not likely to be inherited. Don't be worrying that poor person that they carry something inherited. Whereas other times I'm like, yeah, I can't tell. I need to get a blood sample to figure it out. So hopefully that explains why the two type of tests have different kind of functions. So basically blood-based testing is what we're looking for, or what we do when we're looking for hereditary changes, but the tumor-based sampling, we want to figure out what the cancer type is that we're dealing with. So that's why that molecular profiling is done. So it's a slightly different reason for doing that. So I told you at the outset that I'm not going to go into too much detail about the pathology behind these kind of cancers, and I'm going to try and keep it quite broad. Ovarian cancer. So last week, for anyone that was at the webinar, I gave a load of kind of factoids about how common ovarian cancer is and what the risk factors are for that type of cancer. But today we're going to focus on the rare. So I've skipped over all of that because actually the risk factors that we talk about when we talk about, you know, getting older and, you know, potentially those people that haven't had children or things like that, they're really about the more common types, which are the epithelial types. So you can basically divide ovarian cancer into two broad categories, epithelial and non-epithelial. And all that means is what type of cell in the ovary the cancer started in. Okay, the epithelial subtype is definitely way more common, and that accounts for about 90%. And you can break that down into different types as well, but I'm going to ignore them for the purpose of today's talk. The non-epithelial types are the weird and the wonderful, basically, is how we would kind of, you know, casually refer to them as extremely rare. They account for about 10% of all ovarian cancers, and the standard risk factors that we talk about don't really apply. So these type of tumors can happen in very young people. They can happen in people who have ostensibly healthy lifestyles otherwise. So they're extremely rare. There's a lot we don't understand about them, but we do understand some of the genetic changes that happen. So I'm going to draw your attention to this bottom half of the screen so we can divide the non-epithelial types again very broadly into three categories. There's probably another category that kind of covers the ultra rare, but the main types of non-epithelial cancers that we think about are these types called sex cord stromal, and again that just means the cell type that they arise in. Then you have germ cell tumors, and then you have small cell tumors, and I'm going to talk a little bit about the genetic risk factors of each of these in turn. And you can see the green boxes there are the subtypes based on how they look under the microscope and the cell type that they arise in. The pink box is the corresponding genetic change that we see in that cell. So we can very predictably match these up. So if I see a gene change in the gene FOXL2, for example, before I talk to the pathologist at all, I'll know that that's likely to be a granulosa cell cancer, which is one of the stromal cancers that we mentioned there. So there's very nice kind of predictability, and that's why the molecular testing is so helpful, because if a pathologist is looking at something under the microscope and, you know, he's like, I know this is something weird and rare, but I'm not sure what it is, the molecular testing can be really, really helpful. And changes in these genes, some of them, as I said, can represent hereditary events, but the vast majority of these things occur spontaneously, completely randomly. We don't know why. If we could figure that out, we'd be multimillionaires, because that would crack a lot of cancer risk for us. But you know, what we're here to talk about today is the hereditary risk, the rare types. So I'm going to focus in for a few minutes about the sex cord stromal tumors. Now, again, I don't want to bamboozle you too much. There are loads of different types of these, so they're all kind of lumped into this one category because individually they're so rare. And some of these are associated with really rare hereditary conditions. It's impossible to go through absolutely every rare condition that's associated with these tumors, so I'm going to focus on the more common of the ultra rare conditions that are associated with these kind of tumors. So I'm going to focus in for a second on a condition called Peutz-Jeghers syndrome, which is associated with these tumors called Sertoli cell tumors or sex cord tumors with annular tubules. So if you have either of those type of cancers, if you have not heard of Peutz-Jeghers syndrome, I would definitely ask your doctor about it, because they are very strongly linked with this hereditary condition. It doesn't necessarily mean you definitely have Peutz-Jeghers syndrome, and I don't want to worry people unnecessarily, but it means that you should think about it, and they should, you know, potentially offer you a referral to a clinical geneticist. So the next couple of pictures I'm going to show are of the inside of people's mouths. So just to brace yourself, when I was looking for these images on the internet, it kept coming up sensitive information. So if you don't like looking inside people's gobs, maybe look away now. But the reason that I show this is one of the really characteristic features about Peutz-Jeghers syndrome is this freckling in and around the mouth. So around the lips, on the inside of the cheek, or sometimes kind of on the roof, the hard palate as well. And the interesting thing about this kind of freckling is it's really, really prominent in childhood, but it fades over time. So sometimes when we meet adults with Peutz-Jeghers syndrome, they won't have any freckling. And the first thing I'll ask them is, have you any pictures of yourself when you were a child? You know, can I see what you looked like as a child? And often you will find that they have freckling around the mouth. And the really characteristic thing about this is normally when you have freckles, they don't cross onto your lip. So this thing is called the vermilion border, where you put your lip liner. And the freckles that we have as normal fair people with Celtic skin type, they don't normally cross in onto the lips, but with Peutz-Jeghers, they do. And you have to look inside the mouth as well, because you'll often find it there. The other places you see this freckling is on the fingertips, and actually around the anus and around the vagina and vulva. Now, I don't often ask people to drop their pants so that I can look there, but I will look inside people's mouths and I will look on their fingers for this kind of pigmentation. Now, Peutz-Jeghers syndrome is a very complex disorder, and it's associated with lots of different things. So as I mentioned, the kind of pigmentation is the really characteristic thing. That's something that will give you a hint that that's what's going on. The other thing that people with Peutz-Jeghers get is polyps in the bowel, both the large bowel and the small bowel. And polyps, we talk about polyps a lot in the general population. Polyps are extraordinarily common. So, you know, as we age, particularly if we're overweight or if we're smokers, we'll often develop little growths in the bowel called polyps. Most of the time, they don't cause any bother. Sometimes they can cause bleeding. And, you know, if you leave them there long enough, they will turn nasty and become a cancer. That takes years, that they're not particularly quick, and if you have a colonoscopy and you're found to have a polyp, they can remove it and minimize that risk of anything nasty happening. Polyps in the general population tend not to be this particular type of polyp that people with Peutz-Jeghers get. So people with Peutz-Jeghers get these very characteristic polyps called hamartomas. So again, don't worry too much about the information there on the screen about the pathology. That's meaningless unless you're a pathologist, but they look very characteristic under the microscope. And the way that these polyps cause problems is not so much with the bleeding and the cancer risk, but really what causes hassle is they get really big and they cause the bowel to kind of telescope in on itself. So often children with Peutz-Jeghers will present with this emergency called an intussusception. Say that 3 times fast. An intussusception just means that kind of telescoping in of the bowel. It's a surgical emergency, and those kids, you know, it's not subtle. They're you know, kids that need attention, and you know, sometimes they will get away with us literally shooting up a bit of air up the back passage to sort it out. Sometimes they will need surgery. So certainly if somebody has had a history of intussusception in the past, we would always think about the possibility of Peutz-Jeghers. There is a very high risk of cancer with this condition, and the cancer types you can see are listed there on the screen. Those numbers look really scary, and you know, there is certainly a high risk with this condition, but I think the reason that they're so high is because the condition is probably under-recognized. So in reality, the risks may be slightly lower than that, because the only people we pick it up in are the people that have these really florid presentations. But we do know there is a cancer risk associated with it. The kind of cancers that we see most commonly are things like breast cancer. There's this possible association with lung cancer, and again, you can see the risk quota there are actually really high. I'm not hugely convinced about that particular risk, but you know, we do tell people that's what has been reported in the literature. That's all we can go on. We do know that there's a risk of the kind of gastrointestinal cancers like stomach and the bowel, and that is related to some of these changes that happen. And we see a lot of pancreatic cancer in these people as well. So obviously we need to tell them about that too. The reason that I've mentioned it here today is because we also see ovarian tumours. And again, they tend to be the non-epithelial rare types that I mentioned earlier, the Sertoli ones and the SCAPs. There is a rare type of cervical cancer as well called adenoma malignum. That's a really rare type of cervical cancer that people with this condition get. And if we see that, we do recommend testing straight away. Okay, so these are the type of tumours that I mentioned earlier on. So these sex cord tumours with annular tubules, again, say that 3 times fast. So these SCTATs, but other subtypes have been reported. So certainly if I see any type of ovarian tumour in a woman with that pigmentation or with the history of intussusception as a child, I would want to think about this condition. In terms of screening for ovarian tumours in this cohort, last week I talked about all of the controversies that exist with ovarian cancer screening for the more common types of ovarian cancer. And actually in the non-epithelial cancer realm, it's even more controversial, because the standard kind of markers that we have been exploring for detection of ovarian cancer are those markers that are produced by the epithelial cells. So CA125, as you may know, has been investigated, you know, quite extensively as a potential screening tool for ovarian cancer. That is not going to be helpful in detecting these kind of cancers. So we don't recommend it. It's a waste of time effectively. So we don't recommend doing that. And actually it can cause more hassle than anything, because people with completely unrelated issues can have CA125. So we don't tend to do that. We are not sure if we should be recommending risk reducing surgery to these people. And again, the reason for that is because we're not completely sure about the cancer risks. So we just need more information, and that's very tricky when it's such a rare disorder. So we need more information, and that's why our testing has broadened to include more people with these rare types of tumours. So yeah, that's the type of tumour we're talking about. In terms of how you manage the risk associated with this condition, we recommend screening of the whole bowel. So that involves this camera test called a capsule endoscopy. So you literally have to swallow a capsule with a little camera in it, and that's recommended from as young as 8. So this is quite a serious diagnosis to give a family, because there's such implications in childhood. We recommend the breast screening with an MRI. We're not sure about whether we should be recommending pancreatic cancer screening, but because the risks are so high, we would consider it. And again, we tend to say, or maybe have a gynae exam every year, but we're not even sure if we should be recommending that. The reason we're kind of thinking about it is because of that risk of that rare cervical cancer as well. And it's important to note here, actually, the cervical cancer is not a common type either, and it won't be picked up by the standard kind of smear test because it isn't HPV associated. So we refer these women to specialist gynecologists that have an interest in this particular condition. I haven't talked about the testicular cancer risk because, again, I'm presuming if you have ovaries, you probably don't have testicles, but there is a risk of these rare testicular tumours as well. So we would also counsel about having boys, tested from a young clinical exam from childhood as well. Okay, so that's Putz-Jaeger's. The next rare condition that I'm going to talk about is a condition called Dicer-1 tumor predisposition syndrome. And again, it's associated with these kind of stromal types of ovarian tumors, particularly the Sertoli-Leydig type, and less commonly the juvenile granulosa cell type. So Dicer-1 is a gene that we think about when we see children with tumours a lot, because most of the cancers that happen as part of this condition happen in kids. And actually, it's less common for them to be picked up in adulthood. The kind of tumours, they all have very fancy pants names. Don't get too worried about them. The embryonal bit just means, again, the kind of cell type from which they arise. Pleuropulmonary blastoma is one of the more common types of cancer that these people get. It's a lung tumour. The biggest risk is before the age of 2. So if you're an adult, the likelihood of you developing a lung tumour with a Dicer-1 issue is very, very tiny. But we do see the sex cord stromal tumours as well. So the juvenile type granulosa cell tumours that I mentioned, Sertoli-Leydig cell tumours, and another type of tumour called a gynandroblastoma. So if we see people with these particular types of tumours, particularly in young women, so anyone before the age of 40, we would always consider Dicer-1 to potentially be the culprit. There's other types of cancers listed there. Cystic nephromas are a rare type of kidney cancer, again, much more common in childhood. The big feature that we see, and actually probably the most common feature associated with Dicer-1, is goiter in the thyroid gland in the neck. And again, that's probably underreported in these families because, when we're talking about somebody's cancer risk, we tend to ask about the cancers. We don't really ask that frequently about benign things, but we do see that really, really frequently. And as well as that, we see thyroid cancer. And again, some rarer cancer types as well. So most of the time we pick this up in childhood, but we have started more recently testing older people, including adults, particularly with these rare ovarian tumours as well. So if you have any of those type of ovarian tumours, I would definitely speak to your doctor about, a potential referral to clinical genetics. So again, this is a multi-system condition, basically. So the ovaries are just one part where you can get tumours, but we think about cancer risk definitely before the age of 6. So there's a gland in the brain called the pituitary gland that's sometimes affected. The lungs, as I said, before the age of 2 mostly, sometimes as old as 3, but certainly if you're older than that, which I presume most of you are on the call, then the risk of that is very, very low. The other types of tumours that you can get are listed there. So as I said, the thyroid cancer, and there's also an unusual type, again, of cervical cancer called an embryonal rhabdomyosarcoma. That is the type of cancer I would definitely want that person to come into my clinic because that's very strongly associated with this condition as well. This table looks very overwhelming, and it is, I guess, but what I want to show you there is just the different types of ovarian cancer that can happen as part of this condition. And importantly, from your perspective, should you consider genetic testing if you have any of these types of tumours? And certainly, as I mentioned, if anybody has a Sertoli-Leydig cell tumour, especially if you're under 40, I definitely want to see you in my clinic. The other type of tumour that we want to see is this embryonal rhabdomyosarcoma of the ovary or of the fallopian tube. And again, we've shown that they can be Dicer related. Now, again, the important thing to remember here is Dicer alterations can also happen by chance. in the cancer cells. So they're not necessarily always hereditary, but certainly we would want to see you to test for it to make sure we're not missing a hereditary cause. So that's the important thing with that condition. So the other type of tumour that we think about when we think about the sex cord stromal category are the granulosa cell tumours. And many of you may, on the call at least, may have heard of these type of tumours. Now, granulosa cell tumours, you need to be quite pedantic in terms of your classification because they're completely distinct when it comes to molecular features. So you can divide them into adult and juvenile. Now, when we talk about adult and juvenile, it actually has nothing to do with the age of the patient, although coincidentally, the adult ones tend to happen at older ages and the juvenile ones tend to happen in young women. But the way they're classified is actually because of the cell type, so the juvenile cells, essentially. Adult granulosa cell tumours are by far and away the more common type. They account for over 90% of these granulosa cell tumours. And as you can see there, the mean age at which they're diagnosed is in the 50s, typically after the menopause, actually. And the vast majority of these are completely spontaneous. These are because of changes in the cancer cells that were acquired over time. They're not typically hereditary. There's a vanishingly rare condition that can predispose to this, but people with that condition tend to have unusual features around the eyes and eyelids. So really, if I see somebody with an adult granulosa cell tumour, I'm very reassuring in terms of their hereditary risk, unless they turn around and say to me, well, actually, my sister had an adult granulosa cell tumour as well, and actually I've had eyelid surgery. That's the kind of scenario where we start to get a little bit worried. And I don't mean eyelid surgery as in the normal eye lift. I mean, like, you know, it was definitely necessary for that person to be able to open their eyes, kind of thing. The juvenile granulosa cell tumour is a completely different ball game. So this very, very rare, so it only accounts for about 5% of these already rare subtype of ovarian tumours. The average age, again, is in adolescence, but it has been reported at older ages. So this is what I mean about the juvenile bit doesn't mean juvenile age, it means juvenile cell type. So we've seen them in people as old as in their 60s, but the vast majority of them are before the age of 30. There's lots of rare conditions that are associated with this particular cell or particular cancer type. So I'm talking obviously about the Dicer-1 tumor predisposition syndrome, but there's also other conditions like Ollier disease and Maffucci syndrome, and they're both associated with unusual growths of the bones. So if somebody has an ovarian tumor and they say, oh yeah, I've had, you know, different growths all over my bones and my skeleton is very interesting to x-ray, then I would want to see them in my clinic as well to talk to them about those rare conditions. The phrase there, abnormal karyotype, what that means is your chromosomes, sorry, I should have put in the introductory, so I was saying this to Alice, I shouldn't have assumed everybody was here last week, but basically the way that your genetic information is packaged is in things called chromosomes. So chromosomes, if you think about your genomic information like being the kind of library of your genomic information, chromosomes are like shelves that store the books, and there's thousands of genes located on each chromosome. So genes are like the words in those books. And a karyotype just means your chromosome pattern. So have you got the normal number of chromosomes and the normal type of chromosomes that you expect to see? So sometimes people that have unusual chromosomal changes can also have an increased risk of these kind of tumors too. And again, you can kind of ignore the pathology features there, but they're the kind of features that the pathologist will look at, because, you know, they should be able to distinguish between these types of tumors under the microscope. Not always, and that's why the molecular testing is really, really helpful. So if there's ever a doubt about what type of tumor you're dealing with, we will recommend that they test for these two genes, Dicer-1 and FOXL2, because the adult granulosa cell types will usually have a FOXL2 alteration that has occurred by chance in the cancer cell. And if you don't see that, then you would be more suspicious that actually it might be the juvenile type that you're dealing with. So that's why molecular testing is so helpful when it's in the tumor setting, to be able to kind of clarify the diagnosis and direct treatment accordingly. There have been published guidelines about how you manage people that have Dicer-1 related cancer risks. Again, I won't labor this too much, but just to to kind of emphasize that the vast majority of this screening is before the age of 40. So if you're somebody that carries an alteration in DICER1, then actually your risk, if you get to 40 and you've never had a cancer associated with DICER1, your likelihood of getting one is actually incredibly small. And that's why it's really difficult in these families, because often we will find a child with a DICER1 condition or a DICER1 related cancer, and we test their parents and we find, oh, actually dad's carrier, he's hale and hearty at 45. And, you know, we actually find out that dad's brother had one of these rare kidney tumors when he was 4, you know, so the family history can look really unusual because it looks like it's skipping generations, but that's a myth. So the gene alterations don't skip generations, but the cancer risk can. So not everybody with this condition will develop a cancer. And that's why the screening is, it seems like it just stops and you're left off into the sunset, but it's because if you get to adulthood, actually your risk is reasonably low. And that's why we particularly want to see younger people that have these rare tumours. Okay, so I'm going to focus in now on the next subgroup of these non-epithelial cancers called the small cell subtypes. These are extraordinarily rare. So they only account for about 0.1% of ovarian cancer cases. And you can see that you can divide these again into different types. So you can have this, again, very catchy title, small cell cancer of the ovary hypercalcemic type, or small cell cancer of the ovary pulmonary type. And the type that we would typically see in the hereditary cancer clinic are people that have the small cell cancer hypercalcemic type. That again tends to affect women younger than the age of 40, and actually it tends to affect very young women. So we see a lot of women in their 20s. Sorry, I shouldn't say a lot. You never see a lot of this kind of cancer, but here in the kind of genetics clinic, we would see younger women with this particular cancer. And this particular cancer is very strongly linked to genetic changes in a gene called SMARCA4. And we certainly would offer testing looking for hereditary genetic changes in SMARCA4 to anybody that has this type of cancer. But we do also see spontaneously occurring genetic changes in that gene as well. So we will often recommend doing tumor testing as well to try and figure out if there's something spontaneous that has happened in the cancer cell. Why they develop these spontaneous changes, we don't know, but we certainly want to check for the hereditary ones to make sure that we identify if there's other members of the family at risk of that condition as well. We don't tend to recommend testing in the non-hypercalcemic types because we don't really understand the risk factors for that type, but we haven't linked it with the SMARCA4. So if you have the small cell cancer pulmonary type, that you tend to see that at older age. It's really incredibly rare, incredibly rare. And we don't have a, you know, small cell cancer of the pulmonary type gene test that we can offer. So those people don't typically come to see us in the genetics clinic because there isn't really a test we can do. The other type of cancer that I want to just briefly touch on is gonadoblastoma. So gonadoblastoma, most of these are benign, and I've called them ovarian tumors, which is probably not completely correct, because where we tend to see the gonadoblastomas are in women that actually have disorders of sexual development. So these are people, do you remember I mentioned the karyotype, which is your chromosomes. So normally we have 23 pairs of chromosomes, and the reason we have 23 pairs is we get one set from our mum and one set from our dad. And the first 22 pairs are pretty much the same between biological males and biological females, and they're very imaginatively named in order of decreasing size from 1 to 22. The 23rd pair are our sex chromosomes, and we tend to have, if you're biologically female, 2 copies of the X chromosome, and you get 1 copy from your mum and 1 copy from your dad. If you're biologically male, you tend to only have 1 copy of the X chromosome, which you'll always inherit from your mother, and 1 copy of the Y chromosome, which you'll always inherit from your father. But actually, it's not that straightforward. So it's not always the case that biological females get 2 X's and biological males get 1 X, 1 Y. And that's why the whole discussion about how you determine somebody's gender and sex is really complicated, because actually, you know, without getting into all the kind of transgender issues, even the biological determination of sex is not that straightforward. So we will often see female, people that identify as female, people that were born female, we will often see that actually their chromosomes are not, strictly speaking, what you would expect to see in a biological female. So we have lots of women that do have a Y chromosome, and for various reasons they just didn't go down the biological pathway to developing into a male. That can happen. There can be changes in the embryo, in the genome, that mean the embryo doesn't develop into a male embryo. So we can see these various patterns where you get, a female will have 46XY, they'll have, 45 and only 1X, they'll have a combination of various different sex chromosome abnormalities. And, they may have other issues, but often they're completely normal humans living normal lives, but sometimes they will have other problems as well, often related to fertility. The important thing about these women is often they will have unusual development of the ovaries, because the biology can get a little bit confused. So although they're born female and ostensibly look female, etc., and have female, otherwise the anatomy looks female, the ovaries themselves can be abnormal, or sometimes it may be that they actually have testes. So you have these things called gonads, which is when you can't really determine which category they're in. The danger with those is that they have a risk of becoming cancerous and developing into this, developing into these tumors called gonadoblastomas. So we tend to recommend, if there's somebody where they're born and you can't immediately figure out what gender they are, if they have these gonads where you can't determine whether they're ovary or testicle, you'll often recommend that they be removed because of the cancer risk potentially. So sorry, I didn't realize I was finishing so abruptly, but that's the last of that. So I hope that has been helpful, at least to people with some of those tumors that we've talked about. And I'm very happy if there's any questions to hopefully deal with them now.
Thank you so much again, Dr. McVeigh, for your time and efforts in putting together that presentation for us, which, yeah, it's a complex topic, but it's certainly given me a lot more information and insight. So, yeah, we're really grateful. We've only had a couple of questions come through. If any of our attendees have any final questions, we do have a couple of minutes if you would like to type one into the Q&A or the chat box. So our first question is asking, can women who have had ovarian cancer have HRT, except in cases of granulosa cell? So don't know whether you've got any kind of thoughts on that, or it's a bit of a tangent from this topic.
That's a very good question, and it really depends on a whole number of factors, including what treatment you have had already. Like, strictly speaking, it wouldn't be considered an absolute contraindication unless you've had something that's hormonally mediated. But it's actually such a hotbed. It's so complicated and it's really individualized. Now, what I get a bit worried about is people are often denied HRT because there's such angst about giving it to people. So I think as long as you talk to your doctor and say, I just want to have a reasonable discussion about risks versus benefits, that, to make your doctor aware that you're happy to have a discussion about it, because there's often a blanket, we can't do that sort of reaction, but it's case by case, and it just needs to take into consideration all of the various variables and weigh up, is there a risk of disease recurrence, or is there a risk that there might be some other cancer? Because if there's a suspicion that the woman has a rare type of ovarian cancer associated with a genetic condition that is linked to breast cancer, for example, they might be a bit hesitant about doing it in that kind of scenario. So that's why it's a bit of it's not a yes no kind of answer. So it's just about having a frank conversation with your treating team. But certainly what I hate hearing about is women who, if they had their ovaries out in their 30s or in their 20s even, and then they're just set off into the sunset without anything. It's really worrying, because there are health risks associated with having such an early menopause, including, we talked about this last week, like the reduction in bone density, reduction in, the protective effects on your heart that estrogen has, and potentially the cognitive issues as well. So I think HRT is not you know, sometimes there's this misconception that HRT is only necessary to manage the symptoms of the menopause, which are not fun either. Like, you know, it has a role there too, but there are health benefits of being on HRT as well. So I get a bit nervous when people are so, oh, HRT is evil. You know, I think there's definitely a role for it. And we just need to make sure that the benefits of being on HRT to protect your bones and your heart and your brain are not outweighed by the risk of any cancer recurrence or developing a new cancer. So it's quite a nuanced discussion, which drives people mad when they hear it, you know, but there isn't a leaflet I can make for HRT. It's just too involved, you know.
No, absolutely. And we do have, for that person who asked, there is a little bit more information on our website about that. We have had webinars in the past that have been recorded, which you can find on our website, which are sort of closer to that topic. So it might be worth having a look through and seeing what we've already got there for you to have a look at.
Yeah, I'm a huge fan. If there's no contraindication, I just think I tend to be more reassuring than not, you know. And sometimes that's enough for the treating team if they're like, okay, we just weren't sure, you know, because what they don't want to do is give anything that has a risk if it's not necessary, you know. So yeah, but hopefully those women can be reassured when they have to be, because it's terrible if they're denied a potentially really helpful treatment, you know.
Of course. Yeah. No, thank you for your answer there. We've had another question, which is, can SMARCA4, I'm hoping I'm saying that correctly, can SMARCA4 be the main driver variant in some types of epithelial ovarian cancer as well as small cell? How rare is a change in this gene?
It would be very unusual as a driver in an epithelial type. So if I found a variant in SMARCA4 in what I thought was an epithelial, what I would do is go back to the pathologist actually, and say, are you sure this is what we're dealing with? Now, it's like, as I said, I'm not a pathologist, so there will be some cases where they look at me like I have 40 heads going, that's not something that we would mix up, you know. It depends on the kind of context, but often I've gone back to my pathology colleagues here and gone, the molecular features here are not what I would expect. Would you mind just having another look at it? Because pathology is not easy. Like, I could definitely never be a pathologist, because to me, when I look under the microscope, it just looks like blobs of nothing. You know? But the reason that SMARCA4 profiling is so helpful is when there is diagnostic uncertainty. So if they look down the microscope and they're like, we know this is a cancer, we know that it's in the organ that is the ovary, but actually, apart from the cells being really, really active and us thinking this is, you know, often where it becomes a little bit confusing is if they're very aggressive types, or if the tumor is really like, so there's this thing called necrotic tumors where like the cells have kind of half died off basically, and it's sometimes just impossible to figure out what they look like. You know, it just looks like nothing. Cancer, you know, something bad, but it's not always that easy to figure out what it is. So usually the reason we do SMARCA4 testing is to figure out what category we're dealing with, rather than it being a driver in an epithelial type. So I hope that makes sense, but I would be more so thinking we're dealing with something that's not epithelial if I see something like that.
Lovely, thank you. Our final question is asking, so for somebody who's had a full radial hysterectomy, you know, several years ago, stopped having follow-up appointments again several years ago, is there a need to have, you know, reviews going into the future? If we're talking about a cancer that was, you know, perhaps 5-10 years ago.
That's a really, really, really good question. And actually, it's not a straightforward answer. And we have this London high-risk gynae multidisciplinary team meeting where we discuss these kind of cases, because I know in the Marsden where I work, they will often discharge people without you know, doing onward follow-up for long. But there's real differences of opinion about that, about how long you need to continue people up, and because there's sometimes a difference of opinion about how extensive the surgery needs to be, if it, you know, particularly if it's a borderline type tumor, because there's some places will do as has happened here, a radical hysterectomy and taking everything. Other places will do quite conservative surgery where they might leave the other ovary, or, you know, depending on whether it's a cancerous borderline or whether it's truly a borderline. But it's not a clear-cut answer. But I think, you know, the longer that you're disease-free, the better, and the more reassuring we would be. I'd be much more nervous if they were discharging you after 3 years. You know, I think that's not appropriate. But if you're decades out, then I think, you know, it would be reasonably reassuring in that instance. But it's really controversial, because I've discussed cases at that Pan London meeting where I've like, oh yeah, we discharged them years ago and they just happened to come back because they have a family history of something else. And, you know, there'll be some of the gynecologists be like, oh, they should come back, you know, and then others will be like, no, you know, so there doesn't seem to be a blanket guideline. And again, it's probably, it's person specific. So it depends on the type and how, you know, exactly what level of uncertainty there was about the malignant potential. So, you know, the likelihood of it being sinister and coming back, and other features, you know, like the family history and things like that. So it isn't a one size fits all, but you can be certain that they thought very deeply about it before discharging you, because if there's any uncertainty, they will keep you on their books. So hopefully that's reassuring. But I think, you know, we don't discharge people on a whim. You know, it's we're very careful, particularly with the rare things. You know.
Okay, thank you. I think that is all today. Yeah, we haven't had as many questions as we did last week, which I'm sure is probably unsurprising, given that this is a more kind of niche end of the topic. So we can end there. So again, thank you so much, Dr. McVeigh,